Good evening, everyone. I'm going to try to be brief. I have a few slides here, give you an update of everything Mr. Collector just talked about. So today, here's where we're at in terms of our cases. We have an uptick in Brookline. So that's the norm in terms of when you look at everything that's happening around us. So this slide gives you an indication.
You're muted.
I'm sorry.
Muted.
But I'm sorry, let me go back. Did you hear the first part?
This slide indicates, that's what we heard.
Oh, okay. Yeah, somehow we just muted myself. But anyway, so this is a better indication of, instead of looking at per day, it's very hard to capture that data. It's easy to capture the data per week. So I spent some time over the weekend doing case counts by week. And so as you can see, we were at a low of what I would say in July. But we started to increase as the weather changed. And as, we started to loosen the restrictions. So, the weeks now, we're averaging probably up over 50 cases per week, as you would see. Just over the weekend, we had 30 cases, and that was over a 3-day period. So here's a count by age groups. And as you can see now, where early in the pandemic, it was 70 to 89, 70, 79, 80, 89. Now 20 to 29 lead everybody in terms of the amount of cases. You do see an uptick, as you can expect, 5 to 9, 10 to 19, 0 to 4. But part of the reason you don't see as a large uptick is the kids' viral load is only lasting 2 days. And most times, even if we send home from school, everybody's not getting tested. So that's something to keep in mind. So this demographic hasn't changed. In this category, when you look at white in terms of cases by race, it's 472. African Americans in Brookline, the case of still is at 49. And for Asians at 73. But I still, when you look at proportional wise, based on the size of the population of, let's say, African Americans or whites, African Americans still are 3 times higher, impacted by COVID when you look at the population. So this is a little bit, and this just gives you a graphic. It's symptomatic and asymptomatic testing that has occurred since we started empathy. To test some is the amount of tests that has occurred per week. So if you look like right around Thanksgiving time, we were at 867 tests. That number now has started to decrease now that the holidays is over, but you can anticipate another uptick. Our positivity rate based on these tests, you can see at the high point when we first started, it was at 8%. Now it's down to about 3.5%. So that just gives you an idea of how many tests have been conducted. Been quite a few. And this is a graph to show asymptomatic versus symptomatic testing. The blue highlights the symptomatic, and the orange is the asymptomatic. So you have a high amount of cases of symptomatic testing right around the holidays. That number tends to reduce after that. You have more symptomatic. Now we have more symptomatic people showing up to get tested. So vaccination. So, as Mr. Kleckner, talked about, every state has done something quite different. Massachusetts has just submitted their draft plan for allocations to the state, whereas, Utah is getting to roll theirs out within, next few days, which is totally different. So Massachusetts has allocated 59,000 doses in this first round. The time frame, we're looking at the end of the month, which is one of the reasons I'm trying to purchase a freezer, whether it's Pfizer or Moderna, that we'll be able to at least hold around 60,000 or 70,000 doses. You're looking at a 2 dose, so that means 30,000 people probably be able to receive a dose. Not this go round, but in future go rounds. We have signed an agreement with Massachusetts COVID vaccine program. We did that earlier this week. Actually, we did that last week. I signed off on it. The vaccine would be allocated based on our population. And so, I got the last census data from the state, and it had us somewhere around 59,121. Now, if it goes based on that allocation, it's going to look at the subgroups based on healthcare personnel, essential workers, high-risk groups, and people that are over the age of 65 years of age. So that'll be phase 1, phase 2, which I call phase 1, 2, but it's A and B. And it's similar to what Massachusetts is looking at. I mean, what Rhode Island is looking at doing as well. But they have defined it in their vaccination plan. Phase 1C, you're looking at children and young adults. And of course, that's still up in the air. Now I moved back to, what has happened today in terms of the governor. So we're rolling back to phase 3, part 1, or step 1. And I would just say, as we've went through the phases, the health department, we have received 4,438 calls since the pandemic has started, which is a huge increase. Effective on the 13th, you'll start to see some of the restrictions on outdoor venues. The gatherings will shrink to 25, indoor theaters and performances. That capacity will shrink to 25%, no more than 50 people. The capacity in work areas are shrinking from 50 to 40%. So that's one of the things. Indoor gyms, arcades, retail offices, places of worship, those would change as well. But they're supposed to only have, such as movie theaters, 50%, 50 people maximum anyway. And then restaurants. There wasn't any requirement that you had to necessarily wear a mask in restaurants. Now you have to wear a mask unless you're drinking or eating at that particular time. No more than 6 people per table, 90-minute time limits, which I think that's, probably should be an hour time limit, but 90-minute time limits. No musical performances anymore. Full course seating must be closed in malls, and customers are encouraged to dine only with members of the same household. And then this is the last part of the mandate from the governor. So, one of the parts I would say for everybody is continue to, if people can't telework, continue to telework. What I'm noticing is that in some states, the restrictions are very lenient. And what I'm noticing in those areas is that the COVID outbreak is becoming worse. We are not immune to that. And so I don't know if there's anything we can do beyond what we're doing now. I think we have managed the outbreak as best as we can. Right now, I have all hands on deck in terms of COVID, including myself working COVID cases as much as possible. I'm looking to the MRC in order to get more people to help. But yeah, we are taxed at this point. And so that's the end of my presentation. I'm open to any questions anybody might have.
Any questions from the board? Ms. Feller?
I noticed that in the restaurant section, you didn't talk about the spacing of the tables, and I'm wondering whether that's still in effect, so that people aren't crammed next to each other, but spaced apart.
Yeah, that is still in effect.
The spacing.
The spacing is.
Okay.
Has there been any consideration statewide, nationwide, worldwide of requiring restaurants to use plastic shields between customers at tables? Because people go out. Matter of fact, the governor this afternoon talked about friends of his who were planning to go out and have dinner together. And it turns out one of the couples had COVID. And if they had, unfortunately, the other couple decided not to join them. But if they had been in a restaurant at a 4-person table, you'd have 4 people with COVID instead of 2. So I don't know if that's even practical, but is there any thought to requiring that in restaurants?
Yeah, I don't know how practical that would be. I mean, I've seen it at when you go eat at a bar in that seating area, they've had that up. But I don't know how practical it would be at a table, but it's something to investigate.
I mean, the governor's story was quite compelling, I thought. Any other, Mr. Fernandez?
Sure. A couple questions. I'm intrigued by the data and I have lots of questions there, but I'll talk to you offline about some of those things. I think the 2 questions I have are around testing and then also the vaccine, of course, thing that we're all very excited about, or at least hopeful about. On the testing, I'm excited. I'm glad that we actually are offering free testing for folks who are uninsured but symptomatic. I'm wondering if the numbers that you showed us, are we capturing, what are we missing by not being able to cover asymptomatic folks? And also maybe this is something where Mel can talk a little bit too about how we're funding this. And so folks understand, because folks have been asking us, why not just, and I know folks on the school side have been asking this as well, why not just have a program where we test anybody who walks up that wants to get tested? And so maybe we can talk about both on the public health side and also on the finance side a little bit more about testing.
Yeah, I would just say, initially in the pandemic, and I've been working on testing for the town since, early April and May. And one of the hiccups in providing just all-out testing is the funding piece. And so I tried to work with a lot of, I think in the beginning it was Fallon, and a lot of the requests had to be, we had to make sure we took care of their people up front. It wasn't for sure that we can reimburse. And there was a lot of ambiguity if somebody walked up and there was a close contact, if it could be paid. And a lot of insurance companies were denied a lot of bills. And so that was a huge risk to take on a time, even though I wanted it per se, because it's a good surveillance tool. But it has to be a business aspect of it. Is it practical? And we are already in the red as a town, so I'm very considerate of that.
Maybe I could add a little bit to that. Interestingly, as you saw some of the graph with Dr. Jett's testing, there is a lot of asymptomatic testing going on that presumably is people will file for reimbursement if they're eligible, or they're just deciding to go there and paying the $140 up front rather than trying to wait in line another community which has a safe site, which is subsidized. So as you can imagine, Brookline's not on the top of the list for subsidies for testing from the federal government or anybody else for that matter. We don't have a community hospital like Cambridge, Somerville, and other places to have a natural partner. So we really struggled to find the right testing program. And we said, well, why can't you do it like that, that town or this testing site? And we went through that for literally weeks. And finally, we had to decide, we had to cut the best deal and get testing going. And I'm really proud that this town has had a testing site for several weeks, and it's being used so extensively. I am working with the school department on what they refer to as surveillance testing, which is for asymptomatic sort of ongoing testing. The well-endowed colleges and sports leagues and other employers have been able to do that. It costs a lot of money. This town does not have that kind of money to do that. But what the school department is working on is perhaps having samples of a sample size of ongoing surveillance testing, so that although not everyone gets tested, enough people get tested to provide them with some data and some outcomes. So we're meeting on that constantly. We're meeting tomorrow about that. So we're really working hard to see if we can't have some asymptomatic ongoing testing. But it is going on at our site. And then the other thing I was going to, I'll get into some of the funding issues in just a moment. Happy to answer questions about testing.
Ms.
Well,
Heller?
can I just ask one follow-up question on testing, and then we'll get back to vaccines? But is there any way, are we getting information, or is there any way we can sort of add to our own testing information? Boston University, Boston College, and other colleges, folks where we have folks who live in Brookline are doing this sort of regular, where those of us that are going to campus are required to test weekly at a minimum, in some cases more than that. Is there some data sharing going on there as well, so we can maybe use the data that BU and BC and others might be producing to better understand spread in Brookline?
So, well, for one, any cases that happen with BU or BC, I do receive. And I think it was a couple of weeks ago, Boston College had, an outbreak. They sent a lot of kids home for Thanksgiving, still awaiting the test. So I received the data. We had 50 people at that time at Pine Mountain College that are in isolation. Once that number gets to 75 or 100, then I will have a further conversation with them actually to stop isolating at Pine Mountain College. So because I don't feel comfortable with that, and I'm not sure if somebody's there 24/7 monitoring kids to make sure that they don't leave isolation. So if you notice recently, CDC changed the quarantine guidelines because a lot of people were not quarantining. But I think the same thing is happening with isolation. But to answer your question, yes, I do receive data. If there's anything going on, we had an emergency call 2 weeks ago, actually to discuss some issues.
Thank you.
Can I, Ms. Howell, let me jump in for a second related to that. In terms of community spread or community surveillance as opposed to individual surveillance, are we working or working with MWRA to sort of monitor the sewage, which is one way of determining community spread? And is that possible by town? I guess I just don't know.
Yeah, I'm not familiar with that. I have heard of that. Right now, I would just tell you, working with different entities, everybody seems to be overwhelmed. Even working with the state contact trace collaborative, there was 8,000 outstanding cases that nobody had contacted yet. Yeah. So the public health system right now is overrun. It's just a matter of time before the hospitals will be, which is reason why we really need to roll back this.
Right.
One of the things I would just say, when you really start, if I wanted to put up a map of all of the cases, which I have the address to do, we are overrun everywhere. And overrun, you looking at, we're close to 1,000. But it would truly identify specifically people's addresses as well. Now we at that point where I can identify that on a map. So I don't want to go that far to do that, because that would run into HIPAA. And so I'm standing with that part.
No, got it. Ms. Heller?
I wanted to know whether we have explored any, the use of any of the CARES money for testing, because it seems to me that there may be people who are uninsured or who think they may have been exposed, and then in that case, it's important to test them. But if the insurance company won't pay, would the CARES money pay for that?
So that might be a good segue into the federal funding, because I'm very concerned. Yes, the answer is we've allocated $250,000 of our COVID CARES funding to testing for our current testing site. And of course, we're talking to the schools about how we can help with their surveillance testing. We're very concerned that as of December 30th, the CARES is over, and we'll no longer have that source of funds available to us. And that's why we're advocating, so many people are advocating for Congress to act and extend a new stimulus bill. I cannot, in good conscience, let this testing site go away after December 30th in the middle of a surge. So we're going to have to figure that out and possibly go to the reserve fund for funding. But the CARES funding, which we've used for a number of things, including food security and safety net funding and other things like that, is being used for testing for sure.
and I was on
But
a national
could you
call.
clarify one thing? I'm sorry. 250 is used for the testing, but what is it used for testing of people who are asymptomatic but may have had a contact or an exposure?
For uninsured people, yes. If coverage, if a coverage for test is covered generally by insurance, we're covering it using that part of that 250,000 to cover uninsured people for both symptomatic as well as asymptomatic that is otherwise eligible under CIC guidelines for reimbursement. So yes, we are doing that.
But people who have insurance, but the insurance won't pay for the asymptomatic testing,
Yeah,
so they're out in the cold.
that's correct. That's correct. If their insurance covers it, they still have to pay up front, but at least we will provide them of the receipt with the proper codes that they can then submit for reimbursement. But no, we have not been able to take on asymptomatic testing. The cost exposure for that was really too extensive. So for the whole community.
Okay.
And I would just add, there is the possibility. I was on a call for past president for NATO, and there is talk from the Government Affairs Department that there's a chance the bill will be signed, hopefully before the end of the year, but definitely probably in January sometime. So there's a great possibility that the CARES funding will be extended.
If I can follow up on the question, thanks, about the vaccines. Then folks have heard a lot about sort of vaccine distribution or seen a lot in movies about it. Whether it be like military, everything from military tents to it'll be available at CVS. What is that exactly going to look like? Do you know yet what exactly that's going to look like in Brookline? Is that something that's going to be sort of run by your department or available elsewhere? Just whatever it is that at this point will be helpful.
Yeah, at this point, I really don't know how it's going to be allocated from the state, but I do know health departments, we're prepared to get it because I had to sign an agreement that I would be part of the program. I did purchase a freezer. It might take 30 days to get in, but I've worked with town administration on that. David Janikakis and Justin have been great in helping me get that. One of the things I had to ensure was that, I wanted to make sure it was at negative 85 degrees. So we could take Moderna and Pfizer. I think Pfizer would be the first to roll out, so we're not as much as concerned. But we plan to set it up just like, and this is where the emergency management would come in. We're going to set it up just like we do the flu clinic. So the flu clinics was a test run, and for us to set up to actually distribute the vaccine. And then, of course, we would have to do the screening based on the criteria that has been laid out by CDC and the state at that time.
So it sounds like there are going to be some costs there associated with that as well. Is that right? Yeah.
Possibly. That's one of the things that, we're looking for the state to provide a little bit more information because, it's not going to be free to distribute vaccines. So it's going to be a little bit of manpower.
Thank you.
I wanted I'm sorry, Mr. Chavinsky, go ahead.
I have more than one question, so I'll just take them one at a time if you don't mind. And you've done a good job tonight, and as far as I'm concerned, you've done a good job throughout this whole terrible experience. So thank you very much for everything you're doing.
Thank you.
And you've done a good job tonight of, I think, driving home to people that we are experiencing an increase in Brookline right now. I just want to myself underscore that a little bit in case people don't follow the numbers obsessively the way people like me do. A month ago, and you can correct me if I'm wrong, but a month ago, it wouldn't be surprising at all for the daily report to say we've had, one additional case since the day before, or sometimes even zero. So the number that came across through email tonight is, I'm sorry, I'm going to have to say it's either 15 or 16. I think it's one of those two numbers, but 15 or 16. So think about that, folks that, who are watching this meeting right now. One case maybe a day, 7 a week, a month or so ago, 6 weeks or so ago. at the low point in the experience of this. And now, and I'm not saying this is going to be every day, but we happen to have had 15 or 16, just since yesterday. So things are really changing, as you've done a good job of pointing out. But it does raise questions in my mind. Number one, to what do you attribute this? When I go around town, I still see everybody wearing masks. I don't see that much change. If anything, there's fewer people using restaurants. What do you attribute this to?
So that's a good point. Every surge that we have had in the last few months has been attributed to a holiday. Halloween, I saw a surge 2 weeks later. Thanksgiving, I started to see a surge almost a week or two later. And Christmas would be the next one. So I looked at the dates. December the 8th was the target date that I was looking at for the surge. January the 14th is my next date that I'm looking at for the surge after Christmas and New Year. And I attribute it to, if you look at the graph when I show asymptomatic testing, a large amount of people tested that week. It was 863 tests that week total. But a large amount of it was contributed to asymptomatic people testing to travel. So a lot of people travel during those days, and the weather's cold. And so they go into family gatherings, they meeting people they haven't talked to them who knows how long. And I had this discussion, with the COVID task force. Now is not the time to meet new people or new friends, even family members you haven't seen. I haven't seen my mom in a year and a half. And now is the time, no new friends. And I think a lot of people are going back visiting family members they haven't seen in over a year. And I think you have to keep your circle as it was in January, February. The same people that you talk to every day, that you see periodically during a week or during a month, that's the only people you should be around. When you go out to dine and eat, don't dine close to anybody. If somebody's within that 6 feet radius, I'm uncomfortable. So I would get up and move. I don't like dining indoors anyway. But you have to if you're going to dine in Massachusetts. It's cold. Mm-hmm. So I think a lot of that is attributed to, the nature of the weather, which we had in the spring. We had the same issue. And people are gathering around now more than ever around the holidays.
And just another question on that. So while this has been happening, and I checked the number, and the number we just got is 16. But the number of deaths, thankfully, has been has been low, and there has not been the kind of spike in the number of deaths that we're seeing now in the number of cases. And there was sadly one death since the previous report, but many days there's none. And and most whenever there is a report of a death, it's usually just one, as it was early in the experience of COVID. What are we doing right that is keeping the number of deaths low, and do you expect that to continue, that success to continue, and how can we make sure that it continues to the extent possible?
That's a good question. One of the reasons that we had a high number of deaths in hospitals and coming from nursing homes because there was a surge capacity in the hospital, and they could not take a lot of patients at that time. And they asked people if they had mild symptoms not to come to the hospital, to stay home. So a lot of people that would have showed up didn't show up and died. And what you saw in terms of nursing homes, at that time, we didn't have the medications in order to treat. Now we have remdesivir, and that has reduced the amount of days people in the hospital. But also the hospitals have learned, and as well if I have learned, if I have somebody in isolation that has COVID, I tell them, if you in your confined space, exercise, because that tends to reduce the symptoms. Hospitals are doing the same thing. Instead of allowing a person to be sedentary and intubated on their back, they're now trying to turn people over on their stomach. And that's to help them move and get some airflow. So I think the methods of treating early, there not be a hospital surge, and a little bit of exercise is actually helped reduce the number of cases that you have seen early in the pandemic. And we've just gotten better science now. If the hospitals do hit surge capacity and we do not open up field hospitals, we might be in trouble and return back to that. So I'm hoping not, but I did do calculations, and I predict at the rate we're going now, we can hit 500,000 deaths in the country by May. So hopefully we don't hit that number. We're getting closer to 300,000. So it's not unheard of. If we reach surge capacity, you can anticipate that that's what would occur.
And one more question, if I may.
Yes.
I know that in the discussions that preceded the return to school buildings of the families that have kids in the schools, it was often said that the key factor that should govern that decision is the spread in the community. And now we're seeing a return to quite a wide spread of cases in the community. What is your message to the schools these days?
So, the key is, and I've worked with the school system and also private schools, and it's to continue to screen kids when they come in the door. If they sick or show symptoms, send them home. If they if they're exposed to somebody that is a positive, send them home. And continue to practice the safety protocols. Anytime that there's been an outbreak, and I've watched this around the country, so some health commissioners try to do a blanket order and closing schools or closing private schools. That's something that I don't look forward to doing. But in cases where I've had outbreak in a private school, for instance, I only target those grades that were part of the outbreak instead of closing the whole school. Instead of looking at the entire school system, you look at individual schools. And I think that's a better method to use. Because some schools do better at managing disease and screening, as do others, as you see around the country. So I think the key is if a parent is sick and they have COVID or suspect, the key is to make sure you keep the kid home. And then everybody, continue to practice safe methods in terms of wearing a mask, social distancing, and washing your hands. I think that is key. It's not necessarily to wear gloves. It's not necessarily to make sure you clean your surfaces over and over again. It's really that social distancing and mask is the key to this.
Thank you.
Okay,
Thank you, sir.
Any other discussion? Okay, Mr.
Could I ask one question?
Sure.
On the vaccination plan, are you identifying healthcare workers? Are you prioritizing people who are, for instance, aides and healthcare people in nursing homes as a sort of, and who work on COVID wards or COVID floors as a priority? How are you doing that? Even among the healthcare workers? I mean, there's some who are in the community, they're not nearly as exposed. And I'm just wondering.
Yeah, so that's not necessarily my plan. That's the plan that CDC panel voted upon. And so they didn't break it down into aggregate detail or to granular detail. And so I don't know what that looks like.
Is that going to be broken down further? Is that the idea?
I'm sure the Massachusetts Department of Health to give us more indication or give us an idea of these how many doses that you have per the population, per the subgroup. So, when I have more information, I would definitely come back and brief everybody at that time.